Hello, all you brave people who've hung out for this final session. There may be some more people drifting in, and I understand there will be a more formal closing of the conference after this session. This is a session that I personally feel relatively well equipped to moderate by virtue, perhaps, of the length of time that I've lived with HIV and the great number of years when I dealt with my infection using my resourcefulness and thinking at the time about ways in which I could modify some of my younger habits. I'm no stranger, like many people, including our mayor, to addiction. There, I've admitted it. It's out there in the public domain. Yeah, but I'm not going to apologize. Jake wants me to apologize, but I'm not going to apologize. But you know, we're all predetermined in terms of our genes. But one of the things that we really talk about and never manage to, one of the hardest things of all for us to deal with, and some of the things that are perhaps the most meaningful to this day in terms of our treatment have nothing to do with drugs and have everything to do with modifiable behaviors, and bearing in mind that what our mothers and our grandmothers told us growing up are still true today. And we're going to think about that as we think in this session about modifiable behaviors. So I'm going to invite our panelists to come up, and I'm going to give them very strict instructions because there are a lot of them, and we want to throw it open to questions just as soon as we can. So I'm going to invite our panelists to come up, and I'm going to invite them, please, to take a seat here on the vinyl sofas in what I'm now thinking of as the vinyl cafe. And I have a few instructions for the panelists. We have some very interesting presenters, some of whom we've heard from during the course of the OHTN Research Conference. And because we have so many brilliant minds on stage, and we know that they have so many things to tell us, and we have so little time, that the first thing I'm going to ask everyone is to make 3 key points, try to make them in 3 minutes, please. And I'm going to be watching my watch very carefully to try to keep you to that time. And I'm going to ask, the second thing I'm going to ask people, please, is not to use the word lifestyle. I have a particular bias, a prejudice about the word lifestyle. I don't know what it means. I don't know who has it. I don't know what it. So if you can just avoid the use of that word, I'm going to be a happy moderator. So I'm going to begin by inviting Perry Halkaitis to come and speak to us about issues related to substance use. And I'm inviting Perry first because, unfortunately, he has a plane to catch. And there may be others in the room who can speak to some of the issues that he will raise. But we'll begin with Perry, who is a professor of applied psychology and public health at the Steinhardt School, and came to speak to us from New York. Perry?
Well, let me first say, and I'm sorry that I have to depart early, but my city calls me back and I must return. That it's been a pleasure being here with you all the last several days. It's been for me, a very wonderful experience to get to talk with other folks who are working in the field and to think about the issues not only from a research perspective, but from a implementation perspective and from a policy perspective. And I think that if we're going to affect change in the lives of people who are living with HIV and people who are at risk for HIV, folks like us need to come together more frequently in these kinds of settings. So I congratulate you on an amazing conference. I'm also happy not to be in a room with all academics. So thank you for a wonderful 3 days. I want to just make some brief comments, 3 points as I've been directed about issues of substance use. And the first thing I want to say is that it's pretty clear to me from the work that I've been doing for the last 20 years in thinking about the lives of gay men that substance use does not exist in isolation. And that when we think about substance use issues that gay men and other folks face, these issues are intimately tied to issues of mental health, and tied to issues of sexual behavior. And so that if we're to effectively address substance use issues facing HIV-positive people and people at risk for HIV, we need to address these things simultaneously. There's been conversation about holistic approaches to care that attend to the whole person. I think that in my country, we struggle often with the fragmentation of care. Medical providers don't talk to psychologists. Psychologists don't talk to substance use counselors. Substance use counselors don't talk to social workers. But I think that what we have seen in some of the models that have been most effective, including the models that I've seen in the UK under the NHS, is that the delivery of services in a holistic sort of more wraparound way is going to lead to better outcomes. I would say number two, and one of the things that I learned, in writing the book that I was happy to share with you yesterday, is that if we're going to address substance use in the lives of people living with HIV, we have to do so from a place that doesn't judge. For the men who I interviewed for my book, who were living through the darkest moments of the epidemic, for some of them, substance use was the only thing they had to turn to. There was no hope. They were living in dire circumstances, and use of substances provided a way for them to cope with the realities of their lives. I think third point I want to make here is that whatever approach to providing holistic care we use, and whatever orientation we use, either being a CBT or MI or psychoanalytic, I'm not saying that one's better than the other, that in doing so, we have to address the whole person. We have to, and I want to address one paradigm that I think often gets shortchanged, and that I had an opportunity to talk about a little bit earlier today, which is the importance of 12-step programs in people's lives. And the 12-step programs are often the main outlet for people who are dealing with substance use issues. But they also provide a place where individuals who are experiencing high levels of loneliness and of isolation can come and be with other people who are struggling with the same issues that they are. So I think that we need to think effectively of how we continue to engage with these programs that I believe are often the first place that people go to look for help in the course of dealing with their substance use issues. So I'll leave my 3 points at that. I think I've made my 3 points. I actually may have made 4 points, and I will pass it on to the next person. Thank you very much.
Thank you very much, Perry. I think, one of the questions that we may want to debate coming out of what you're saying is, in terms of where people can access treatment in a holistic manner, what makes the most sense. And I know you can't really stick around for that, but I think sometimes we have questions about where service should be delivered and how we build expertise beyond the walls of our AIDS service organizations, and how we make good use of other care providers in our environment to ensure that we can have access to holistic care for people. So where do we get those services, and how do we build the expertise we need outside of our own sort of confines?
I think it's a really great question, and I think that we can definitely think about building structures and looking for structures, but I think that there's another piece to it that I'd like to respond to, which is I think that our medical professionals, those who provide services for treating people with HIV, need to be aware that people who are living with HIV, like myself, are more than just vessels in which the virus is floating around. And so engaging with medical practitioners and having them understand that there is not only a biological health, a physical health, but there is a psychological health and a social health, and training medical professionals in the future to recognize the totality of people's lives is probably the most effective way to ultimately link all our care providers in a meaningful way. That would be my response.
Great, thank you very much. Thank you. We're going to move along, and we're going to hear from our speakers, and then before we open the floor to questions. And our next presenter is going to be Adam Moskovich, who is the Associate Clinical Professor with the Faculty of Medicine at the University of Calgary. And Adam is diplomat with the American Board of Sleep Medicine, and the American Board of Psychiatry and Neurology, and the American Board of Forensic Medicine. He's developed an accredited case-based discussion for healthcare professionals related to sleep and HIV, and gave a wonderful talk at our lunch on Monday. And boy, do I have a question for you.
Okay.
Would you like the mic?
Sure. Okay. Can you hear me okay with this one?
Yeah,
I'll do it. Do you have my slides? Wonderful. Okay, and where is the control? I guess that we don't have the control, so let's forget about it. Anyway, the first message is that we probably should have had the person that was talking about stress management talk first, and then you all would be taking a nap. And then I could be doing some demonstrations. But more on the serious side, and to pick up from the comment about that we need to look at ourselves and at our patients in a holistic way, my key message is that holistic also means in a 24-hour cycle. And medicine had a tendency of spending all our resources on what's happening during our awake state, to a great extent ignoring the importance of what's happening during the sleep state. The second message there is that what's happening in sleep is absolutely crucial, both for our physiological, psychological, occupational, and educational well-being. And if we are not getting the right kind of sleep and the right length of sleep, so it's balance between quantity and quality, there are some very serious consequences. And then the last message is that in a similar way to the general population, the prevalence of sleep disorders that we recognize is extremely high. About 10 to 15% of our society is believed to be, first of all, chronically sleep deprived, simply not getting as much sleep as we need without having a medical condition. And then you have a multitude of sleep disorders, which over the last 20 years we have recognized and we can effectively treat. Some of them are what we call primary disorders, such as breathing problem in sleep, sleep apnea, narcolepsy, restless legs, etc. But we also have a whole spectrum of secondary conditions. Now, in the HIV population, obviously you will have some of those conditions the same way like in the general population. But there are some unique aspects to living with HIV from the sleep perspective. For example, the effect of the illness itself in terms of causing fatigue and sleepiness. Some of the side effects of the medications, both in terms of the HIV medications and some of the other medications that you might be taking, have an effect on sleep and might have awake state consequences that have to be factored in. The other issue is, if you don't get the right kind of sleep, it weakens your immune system, makes you much more vulnerable to certain infections, including fighting HIV as a result of that. So this is a very important area. Sadly, there are very few clinics that screen routinely for sleep disorders as part of routine practice, which was the impetus of why we put this program together, essentially to educate the clinicians, first of all, and to raise awareness, including developing some basic tools of how to screen for the more common disorders, manage some of those things, both behaviorally and pharmacologically when required within the clinic, and also know when to make a referral. And on that note, I will sit down, and hopefully you will have a great sleep tonight.
I know that I and others are going to have a number of questions for you, so are you able to stay with us? And, sure. Excellent. I'm afraid I'm going to introduce now Deborah Kennedy, who's with us to speak for with 3 main points on nutrition. Deborah, I have to apologize that I don't have bio for you. Can you introduce yourself?
Sure, be happy to. My name is Deborah Kennedy, and I'm a practicing naturopathic doctor, and I completed my PhD at the University of Toronto. And my topic is nutrition, and nutrition is really, in my view, one of the cornerstones of being healthy. It is the food choices that we make represent the fuel that powers our body. And I think that many of the changing agricultural practices that exist in terms of modernization have shifted the choices that we make, forcing us perhaps to opt to be to eat on the run, to be convenient, to not know any longer what is actually in our food. So, for example, high fructose corn syrup, which we're coming to understand from a research standpoint, can dramatically increase the shift to type 2 diabetes, which is a concern for all of us. What's the impact potentially of having genetically modified food and intaking that? And changing agricultural practices such as grain feeding our livestock has had an enormous impact on, let's say, the composition of the food that we eat in terms of meat, shifting the ratio from a balance of omega-3 and omega-6s to almost exclusively omega-6s, which results in us needing to supplement with fish oil in order to reduce the inflammation that high levels of omega-6 have on our body. So nutrition, sleep, I think each one of the panelists represents some of the cornerstones of living well and healthfully in the 21st century. So thank you very much.
Thank you, Deborah. I think there are a lot of questions for you as well. Because I do have my eye on the time, I'm not going to do the full biographies of our speakers, many of whom have spoken during the course of the conference. I'm going to ask Aaron Blashill, staff psychologist in behavioral medicine at Mass General, to speak to us about benefits, 3 main points. Aaron.
Happy to. So regular physical activity can really be a very powerful intervention that addresses multitude of negative health outcomes. So we know that regular physical activity can help prevent cardiovascular disease, diabetes, some forms of cancer, osteoporosis, osteoarthritis, obesity, depression, anxiety, substance use. It can help decrease fatigue. It can help improve sleep, can help improve one's body image. It really, a lot of things under the sun. And there's been some really well done research looking at this specifically within folks living with HIV as well. And I think that physical activity or regular physical activity might be even important for folks who are living with HIV. One of the things that has been discussed quite a bit at this conference is the chronic nature of inflammation. We know that regular physical activity helps decrease that inflammation. So physical activity is helpful for everyone, I think particularly helpful for folks living with HIV. And unfortunately, like the general population, folks living with HIV aren't getting, on average, the required levels of physical activity. So it is something that we really need to look at, how we can help increase that. The CDC has some guidelines in terms of minimal levels of physical activity, which are about 20 to 25 minutes of moderate aerobic exercise per day. So that's about 150 minutes a week. So that can include things like brisk walk, water aerobics, even mowing the grass, as long as it's not a rider lawnmower. Or you can look at more vigorous physical activity where you might need less amount total. So 75 minutes a week for more vigorous activity like tennis, basketball, swimming, running, jogging. And that needs to be combined with some strength training as well for about at least 2 days a week. So lifting weights, use of resistant bands, push-ups, sit-ups, yoga. Those are all activities that can help strengthen muscles as well. There's been some recent meta-analyses that have looked at the effect of physical activity or regular physical activity in predicting immune function and virologic outcomes for folks living with HIV. And the data there looks a little bit mixed, that there might not be a strong direct relationship, but I think it's important to consider what might be some indirect relationships. As we just talked about, regular physical activity helps improve mental health, create some structure in one's day. We know that these are really powerful predictors for increasing medication adherence, which of course that's going to be a strong driver to improve CD4 counts and reduce viral load. So we have to look at indirect in addition to direct relationships as well. One other point I want to make is that there's been some recent data coming out from the US that rates of overweight and obesity are really on the rise amongst folks living with HIV as well. So that combined with the chronic inflammation, I think really raises the salience of trying to incorporate regular physical activity into the lives of folks living with HIV. So, and one final point I'll make as a clinician working with folks with HIV quite a bit, one of the first things we assess when I'm meeting with a new patient is what's your sleep like, what's your exercise like, and what's your nutrition like. Those are real pillars for well-being physical and mental well-being. So it might not be sexy to a lot of patients, but I do always assess that and try to find ways that we can make modest improvements. And lastly, might be point number 4, but even if you're not getting the minimum levels of physical activity, anything helps, particularly if you can get 10 minutes or more of sustained physical activity. So everyone's got to start somewhere, even if that's maybe a walk around the block a couple times a week. Anything that you can do to help increase physical activity is going to lead to some health benefit. So that's what I'll leave you with.
Great. Thank you. Thank you. It's a perfect segue for our very own Sean Rourke to talk about brain fitness.
So, is this working? It's working? Yeah. So, my 3 points.
Yeah.
I'm going to talk about brain health, and in some ways I could have gone at the very end, but I'll go kind of in between. My first main message, I guess, is that whatever is good for your heart is good for your brain. And that's actually a very powerful statement for a few different reasons. But everything that you're hearing today, or all the panelists, so all the things that we're going to be talking about are good for your heart. And we know, so the more that you take care of your vasculature, the better you'll take care of your brain. So that's a really important message. I guess the second one is there's no magic pill. And I think the related to that is that prevention is probably the best strategy. When you're thinking about cognitive or neurological or brain health, when it becomes a problem, it's usually further down the way. And the best strategy is actually do something in advance. So all the things you're going to hear about today, nutrition and exercise and sleep and reduce alcohol and don't smoke, all those things are all good prevention strategies. And I think we should be starting to think about actually not waiting. I think Steve Deeks did a very nice talk with talking about the importance of exercise and other things and inflammation. I think anything that reduces that is going to be good for the brain. The last point is around exercise. It's just building and exercise, and more exercise. And as you say, half an hour, 10 minutes. There's a great video, 23 and a half hours. Mike Evans is a physician, family doc at St. Mike's. Look it up. It's a great little story for 10 minutes about that half an hour a day. Find it, do it, it works, and it's good for everything that we do. So, and related to the brain fitness, I think the last point is that what we're finding is that brain games, so that you see Luminosity, you see all these advertisements for these things. We started to evaluate these. We have a pilot study. We've done it in 15 people. It works. Not only does it work, so it reduces people's symptoms, their symptom burden, makes people feel that they can better, their attention is better, they're remembering more, but it also changes our cognitive test scores. So there's something there happening, and it's the activation. 95% of what we do, except for this conference day to day, right, is the same. And so if you, like with exercise, you get blood flow going, and there's lots of neural networks in our brains. If you get them activated, getting them doing different things, and practice those, you get blood flow and neural networks connected that actually are good for us. So not all the brain games are good. We're using one called Brain Fitness. It's a company in California called Posit Science. We're at that stage of going to a larger trial. So our pilot data suggests that it is very promising. We're going to need a larger RCT to show that it actually works in the bigger scheme of things. But I think there's lots of hope there. There's no magic pill. Antiretrovirals are very, very important, but we have to look to other things. So it's everything on the panel today, exercise and blueberries and strawberries and doing your brain games.
And curcumin. Thank you very much, Sean. And again, I think thank you. An excellent segue for Evan Collins, physician, researcher, PHA advocate, consultant, and general friend and man about town, to talk about mindfulness-based
stress and mindfulness.
Stress and mindfulness.
Okay.
Thank you.
So this sort of reminds me of speed dating. You get a couple of minutes. So
speed speaking.
So point number one, stress is huge. Dr. Moskovich has already identified that really stress is a common denominator for everything we're talking about. And I was prepared to quickly review some of the literature, but I don't have to because intuitively we know that. Number two, of a number of different interventions that have been shown to be effective in dealing with stress, mindfulness is one in which there's a growing evidence base, and it's very popular now, it's trending. So I guess for that reason, they asked me to speak on it as a HIV psychiatrist who also teaches mindfulness-based stress reduction and mindfulness-based cognitive therapy. So mindfulness, in short, is both a skill and an attitude, best described as non-judgmental awareness of present moment experience. And it's usually cultivated or taught through 8-week programs, either MBSR, mindfulness-based stress reduction, which focuses on stress, or in combination with cognitive therapy, an intervention called MBCT, mindfulness-based cognitive therapy, which focuses on stress and also some related mental health outcomes like depression and anxiety. And there is a growing evidence base for it. Specific to HIV, there's only been a modest amount of research, but I will profile in closing one study that is notable because one, it came out last month in AIDS and Behavior, and two, because there are some very compelling, strong results, and three, because mindfulness, which I gave a very short description of, and it probably doesn't impart to you fully what we do to help people train in it. But mindfulness is wacky for some and on the fringe, so it is worthwhile stressing the research that's out there. The Barcelona group at the HIV unit at the University Hospital, a very active research institute in Europe for HIV, they took 40 men and women with HIV over the age of 50 who had been on antiretroviral therapy for 15 years or greater. They randomized to receive either 8 weeks of mindfulness-based cognitive therapy, a manual-based intervention, or treatment as usual. And they monitored people before the intervention, at the end of it at 8 weeks, and 3 months later, so a total of 20 weeks post-baseline. And what they found is that there was a significant improvement, statistically significant and presumably clinically significant as well, in quality of life, in all domains of quality of life, including sleep, physical activity, pain, and mental health. There was a statistically significant drop in depression and anxiety using the Beck scales, and a significant drop in stress using a standardized scale called the Perceived Stress Scale, something we use. And very intriguingly, there was a significant boost in CD4. On average, the people who received the MBCT at 20 weeks gained 130 cells per cubic milliliter, compared to the control group, which basically stayed flat. There was actually a decrease, a slight decrease. So this is just but one study in the new area of mindfulness within HIV. Sean and I are working on our own study, also looking at MBCT, looking at it not only for mental health outcomes like depression in our population, but also in mild neurocognitive impairment. So more to come, we hope.
Thank you. I think it will hopefully raise some questions from the audience about the importance of doing research and the valuing of different types of qualitative research in terms of enabling us to understand the effectiveness of these interventions. I'm going to pass it now, please, to Dr. Amit Rotem, who is a psychiatrist and addiction specialist from CAMH, who agreed to pitch in at the last moment for us this afternoon. Thanks for coming, and if you could make 3 points about smoking cessation and particularly for people with HIV.
Thank you very much. Do you hear me?
Yes.
Great. So thank you very much for inviting me. So cigarette smoking is, unfortunately, with its nicotine addiction, is the first leading cause of the preventable death worldwide. People living with HIV are not an exception. We know but with randomized trial controlled already, some done in CAM-HIV in Toronto, that people living with HIV that quit smoking or stop smoking successfully live longer, healthier, and a happier life. What do I mean? Longer, at least, well, let's say between 2 and 5 years on average more than their friends that continue smoking. Healthier, I mean higher CD counts, less manifestation of AIDS syndrome, less TB infections, and higher antiviral effects of the medications. And happier, we see much less depressions and, by the way, less anxiety with people who quit smoking, and do say that not only longer life, but much better. Well, cigarette smoking is actually based on nicotine addiction. Nicotine is one of the most addictive drugs that we have at present. However, there is an effective and a safe treatment for stop smoking, which is the combination of pharmacotherapy and behavioral, psychological support. We treat many people living with HIV in our clinics. I know that also in all over Ontario through our TEACH program, we try to teach or train other trainers how to address specifically people living with HIV for their concerns, so they can help or get better treatment for smoking cessation, meaning asking or interesting more about other substances that they use that is concurrently with the cigarettes, their depression or depressive status, and other mental illnesses. And we know that only when we develop this holistic approach to these people living with HIV, then they can quit smoking with less difficulties. Just to end with the personal perspective, I can say that there's one of the most rewarding feelings I get from my clients who quit smoking with live HIV, coming proudly after not more than even 2 or 3 months without cigarettes, coming with the updated CD4 count to show me how it got up, which is not anymore a surprise, but it's almost happy for the clients, as of course for me, the therapist. Thank you.
Thank you very much. I'm going to pass it now to Paul Schuper, who is Senior Scientist in the Public Health and Regulatory Policy section of the Social Prevention and Health Policy Research Department, also at CAM-H, and who's going to talk about alcohol and alcohol use and HIV.
Yes. Can you guys hear me? No? Let's hear it. There we go. Hello? Number 1. Hello? There we go.
There we go.
Okay, great. I just wanted to talk briefly about alcohol and HIV. Alcohol is sort of the forgotten drug. We talk a lot about other drugs, methamphetamine, cocaine, but alcohol, it's socially acceptable. It's legal. There's less of a stigma with it than some of the other drugs. But when you look at alcohol and HIV, there are definite links within that realm. So, for example, alcohol is associated with unprotected sex. It's associated with longer duration to getting tested for HIV, later entry into care, longer duration to getting on ART, poor ART adherence, and poor treatment outcomes. So, as my first point, it's just reiterating the fact that there really needs to be a focus on alcohol as kind of a major factor within the realm of HIV, and which in some cases alcohol gets left behind compared to the other drugs out there. The second point I would make is that very often these alcohol-related problems, such as alcohol abuse, heavy drinking, they're not found on their own, and this sort of mirrors some of the points that Perry had made earlier. You see things like depression as being quite prevalent, other mental health concerns, even concurrent substance use within this context of heavy drinking or alcohol dependence. So you do see a lot of these factors coming together. And then just briefly to wrap it up, my final point would be that things can be done to help people who are living with HIV and who may be worried about their alcohol consumption. One of the things from the get-go would be trying to link alcohol programs and alcohol resources to HIV care. Alcohol consumption and heavy rates of drinking are much higher among those who are living with HIV than those who aren't infected. So trying to build in alcohol-related resources and programs into those settings could be very beneficial. Also, some people are very happy with their levels of alcohol use. They're not at problematic levels. So they might not want to reduce their level of consumption. But in those cases, there could still be a focus on trying to come up with strategies to use condoms even while drinking, because some people are very successfully able to do that. Also trying to take medications even when, anticipating on being intoxicated. There are even situations where people perceive that they should not take their medications if they've been drinking. I've also seen abroad in some cases, providers will be giving out that information to patients saying, don't take your medications if you're drinking. So some of those things need to be, that misinformation needs to be corrected. And again, just having good relationships between providers and individuals who are receiving the care could help, and opening up the discussion on alcohol within the context of HIV could be very beneficial. Thank you.
Great. Thank you. I'd like to invite people to go to the microphone. Is the microphone live back there? I see a couple in the room. Come with your questions for our panelists. And while people are coming to the microphones, I'll try to start it off with a question of my own. As I was listening to everyone speak, I thought to myself, I guess one of my personal goals over the years, particularly before I had access to triple therapy, was to try to modify some of my own behaviors and dealing with addictions I referred to, one of which was cigarettes. And I haven't smoked now in over 25 years. Bravo. And my other addiction, which actually was to a sleeping medication, which I wanted to talk about. And the degree to which, we live in a society increasingly where, we want drugs and pills to throw at things. And here we have a range of experts who are perhaps more equipped to talk to us about ways in which we can avoid the use of drugs and those kinds of interventions, and ways in which we can use exercise and other kinds of interventions. So just to get some perspectives, for example, on recent research that suggests that for cardiac patients, I'm also one of those, that there may be benefits to exercise, for example, that actually outweigh the benefits that could be derived from certain drugs used to lower blood pressure and so on. Maybe, Aaron, you'd like to get it rolling by speaking to that. But I'm interested to know what people think about the degree to which we can use some of these various behavioral interventions and so on, modify our behavioral risk, and avoid the future that is promised to us of polypharmacy.
Sure, and I probably will defer to one of my MD colleagues to address the issue about whether certain medications might be more or less effective than physical exercise. It's a bit outside my purview. But I think that physical exercise, physical activity in general, can be a real stress reducer. And we oftentimes look to alcohol, substances to help reduce the stress that we may be experiencing. And when we look at trying to increase physical activity in our lives, it might replace that. And as I talked about earlier, it has a host of additional benefits to mental and physical well-being. So it could be a really helpful strategy for supplanting maybe less helpful coping strategies. And alcohol and substance use is a coping strategy, just doesn't happen to be a very effective long-term strategy. So I'm not sure that answered your question.
No, it's helpful, and I don't know if there are other people in the audience who want to say anything about how exercise helped them avoid having to take a medication or developing a yoga practice, for example, which is something that's become very dear to me. Jake?
Okay, I found out I was diabetic. I had type 2 diabetes because of medications I was over.
Thanks, Paul.
Thank you. I discovered on medications that I was type 2 diabetic. The discovery was unusual. I couldn't stop eating, and I was always hungry. But exercise helped a great deal, and eventually I was able to get off the diabetes went away when I changed the medications.
It reversed the metabolic syndrome.
Kaletra was the culprit. But the diabetes was a shock because the doctor said, you're diabetic. I didn't know, I heard the word all my life, but I didn't know what it meant. I had to suddenly learn what that was all about.
Great.
Exercise helped a great deal.
Thank you. So there you have, an interesting example of how exercise could be of benefit in terms of glucose tolerance. Yeah. Mm-hmm. Yes.
Let me make a comment about what you said about
hooked on Zopiclone.
Hooked on Zopiclone. Okay. Hypnotics, which is what we call sleeping medications, are the most commonly prescribed medications out there in practice. It's a multi-billion-dollar industry, and it's a huge industry also in what we call non-prescription items. And it's a fallacy that some people think that if it's not a prescription item, then going into a health food store and picking up an unknown amount of melatonin, for example, or 5-HTP, or any tryptophan or any of the concussions. Actually, tryptophan is a prescription item. I'll say something about that in a second. So it's never a solution on its own. And that's a key message. If all what you are doing is trying to deal with your problem by taking a sleep aid, you're not managing it appropriately. Now, especially when it's a chronic sleep problem, the starting point should be that insomnia is not a diagnosis, it's a symptom of an underlying condition, and your doctor should know what the underlying condition is, and you should press to know what is a particular problem that you're treating. Because if what's causing, for example, your problem is waking up at night because of snoring and some pauses in breathing, then actually using a sleeping aid will make that condition much worse. So it's not only can be not helpful, but it can aggravate the condition. Once we excluded those things, then the trick is using the right pill for the right duration, while parallel to that, the same way like in smoking cessation, for example, working on behavioral measures, so eventually those things can replace the need for the pharmaceuticals. And that's usually the approach that we take with chronic problems in our practice, is getting people on behavioral measures, which can include meditation, relaxation techniques, sleep hygiene measures, cognitive behavioral therapy, etc., using pharmaceutical agents when appropriate till those measures become effective. I use tryptophan a lot, in particular in individuals with addiction potential. It's an amino acid that is essentially non-addictive. It comes in prescription, so we know exactly what you get, makes sleep much deeper with some very good results, and then we withdraw people once the behavioral measures became a lifestyle.
My own story is one that I think is actually quite common in community. I never had any issues sleeping, but I developed them while on a particular medication that shall remain nameless, but whose initials are Sustiva. Big surprise. And then couldn't get off it. So again, we need to be mindful of how it happens in our community that people can end up hooked. So Bob, we'll go to you at the microphone.
Okay, thanks, Ron. It's Bob Leahy from PositiveLight.com. I guess I've got a question about how you make interventions in some of these modifiable behaviors more successful, and particularly in the role of service providers. And I guess this comes from a position where we're doing some work now on smoking cessation programming for people living with HIV, because, as you mentioned, sir, rates are higher in people living with HIV. But we also have a case where smoking rates are higher in service providers, the people who run the agencies, the counselors. To what extent do you feel, and I guess the question is for both the cigarette smoking and substance use, to what extent do service providers need to model the behavior that the intervention is in other words, can you have service providers who smoke? Can you have service providers who have addiction issues? And if is that acceptable? Is it not acceptable? If it is not acceptable, how do you sort of tackle the ball of wax?
Great question. Who wants to respond to that?
I think get him to help.
Well, from my, you hear me?
Yes.
From my perspective, I mean, we can have a whole conference of what you asked because it's a really matter of policy. Well, first of all, from the therapist's perspective, we know that those with the problem have much more problem to deal with it with those who need, with the clients. I mean, as an ex-smoker, I can develop empathy toward the smokers, but if I were a smoker, I think that the cigarette would be present in the room. That's for sure. Now, talking generally about the aspects of how to deal with smoking within institutions, I can tell you CAMH, by the way, is a very good example because it's turning these days to be tobacco-free. I mean, not only smoking-free, but no cigarettes at all campuses, like in other, by the way, hospitals in Western world and in Toronto. So yes, we had to, and we still invite smokers from the staff to enter or to join smoking cessation group support, to have medication, nicotine replacement for free. We do think that counseling and supporting the managers also with this addiction is very, very important to implement the change. Yes, if you're asking if the fish stinks from its head, yeah, I mean, it's nothing's new here. And we know that if there's in places that we found some obstacles in implementation smoking cessation therapies, I can say also in Qatar, but also from Israel, where I come from, there's lots of, and you then go and see and make your inquiries, what happens and why the managers don't want this or have other priorities, you get to the point that they smoke themselves. So, and the priority suddenly changes. So yes, it's very, very important. And I think that if you want to implement any changes, it should begin from the directors. And there are ways, there are guidelines, there are Canadian guidelines how to implement this. There are the CanAdapt guidelines. And again, for people living with HIV, shouldn't be exception. It should be the same, actually. Yeah.
Thank you. Marek.
Thanks, Ron. Thank you to the panel. I think a lot of exciting and interesting talks there. A couple of points I wanted to make. The first is one of the, I won't call it lifestyle because Ron will kill me, but one of the things we don't think about is also oral health, brushing your teeth, flossing your teeth, seeing your dentist. I think is one of those other factors that affects inflammation, quality of life, whether you have teeth down the road and so on. But I would ask the panel, other than, let's say, diabetes, where I think there's about a 50% prevention from regular exercise, I don't think we have good estimates of how well these work and how good are people at actually doing what they're supposed to be doing. So my one plea is, please let's not throw out medicines that we know for sure work in the belief that changes that we've made that may not be sustainable or may not be adequate in terms of exercise or sleep hygiene and so on. And a huge example for me in this is statins for cardiovascular disease. Even after heart attacks, the adherence to statins, which is a life-saving drug, better quality of life and so on, about 50% of people post-MI stop taking their statins. Within HIV patients, I often have a reluctance to take statin drugs, even though they're probably one of the safest drug classes ever developed. So my plea is not to see exercise and diet as an alternative to life-saving drugs. They work together. Clearly, we can prevent diabetes with more exercise, and then we won't need it. Clearly, hypertension is better treated with the help of these, and clearly, sleeping medicines are overused. But some drugs like statins, vaccines, and HIV drugs have had this long, debate about alternative. And I think these things are complementary, not alternative.
And I don't think that there is anyone on this panel here that would not agree with you. It's not black and white, all or none. It's appropriate combination.
Mm-hmm. Sean?
Yeah, Merrick, great. I don't know, is this working?
Yep.
Great points, Merrick. I think, too, one of the things that was very striking in Steve Deek's talk the other night was the work that they're doing, and we're starting to do here in Ontario, using Amy Justice's VAX index. And what that's telling us is that slight elevations in organ systems are important to pay attention to early and not let them get to the point where you're actively using a drug. And so I think that's the other the context to that too. Statins and aspirin, as Steve was saying too, are very important and potentially very useful. But I think we need to be thinking about earlier interventions and health promotion strategies to get people to think about, and the medical system as well, to realize that slight elevations in liver, kidney, this and the other thing are actually clinically significant in people living with HIV. And the standards, and particularly as people are aging, and this whole inflammatory concerns that occurs. So I think that's the context that we're not talking about, that the standard guidelines and benchmarks are not being applied perhaps earlier as they should be, particularly as people with HIV age. So I think, and you probably have some comment to that, but that as a non-physician, I see that data, and it's pretty striking that we should be developing better health promotion strategies earlier than waiting for them to sort of, to act when things are moderately elevated.
Thank you. Mark?
Can I just make a very small comment?
Sure.
I fully agree with that, Sean. I mean, one example is, let's say, blood pressure. We don't tend to diagnose high blood pressure until it's 140 on 90 on a number of occasions. The Americans label high-ish blood pressure as pre-hypertension, and I think that's a much better idea, because that's when you can make lifestyle changes that almost, changes in which almost certainly will affect that. So changes in diet, changes in exercise, I think, are a lot better when your systolic is 125 than when it's at 145.
I'd like to thank everyone, but I'd also like to summarize a few things that I feel I've heard and that I would like for all of us to think about or take away from this session. Is there another question? Sorry, Dave, I didn't see you. I've got a very bright light in my face. Go ahead, and then I'll try to summarize.
Yeah, I was at a seminar at the YMCA recently, and they showed a graph, I think, for just for a normal person, that the importance of aerobic exercise. And so, Sean, you said whatever is good for your heart is good for your brain. So I took away from that presentation that I should do some aerobic exercise in my workout. So right now I'm using a treadmill, and for 4 minutes of interval training, getting my heart rate up. So that's one thing I'm doing. And the second thing I'm doing, you also mentioned this posit science, these brain games. So can you talk a bit about aerobic fitness, helping the brain, like keeping the heart rate up, and also about which sites can we go to that you think are the best?
Actually, physical exercise, we think as well, is good for the brain, and certainly longitudinal studies in aging are showing that. And I think it just makes sense, and we're going to see study after study showing that in the next couple of years. So as my colleague beside me has mentioned, just find ways of doing that, and all the other things that are happening or that people talked about on the panel are actually part of that health promotion. What's good out there and not so good? I'm seeing studies coming out or results of these brain games evaluations. Some are going to be good, some are not going to be good, unfortunately. What's going to be important, though, is doing something for a sustained amount of time. So it's actually weeks to months that's going to be important. It's just like any kind of physical exercise and physio that you get when you hurt a muscle or a bone or ligament, and that's what it's going to take. I think some of these, that they promote of just doing these games, you get good at it, and then the effect is lost. you have to be, exercise is something you got to be sweating. So with the brain as well, you have to keep it, once you do the puzzle, and you get good at it, you've lost that benefit. So you have to increase it to something else and challenge the brain, just like any kind of physical exercise, to get the blood flowing and the muscles and everything sort of working. The brain is a physiological organ, just like our muscles. So if you think of it that way, just keep on working it.
It's the Olympics. Citius, Altius, Fortius. Faster, higher. Again, thank you to all of our panelists.
Get one more thing in?
And we do. Oh, we have one more.
One more.
Adrian.
Is that okay?
Do we have time? Is our
Really
time
quick.
okay? 5 minutes? Go.
Just a note of caution about planning these interventions. As a PHA, and as an overweight PHA who smokes, who sometimes sleeps badly, who doesn't always eat as well as he should, who's also a service provider.
And a good one.
Shame-based approach, right? Remember the language we use, remember what we're saying, and be mindful of how we speak when we speak. There's already so much shame and stigma piled on our shoulders as PHAs that when you're talking about my eating habits, my smoking habits, my drinking habits, my sexual habits, just a friendly reminder that I don't need any more shame piled on my shoulders. Thank you very much. So that's...
Hear, hear. Hear, hear. I think, also Jake? The questions keep on coming. Go ahead.
One more little item.
Yep.
It just occurred to me because of this notion of using the brain to exercise the brain. Something that I'm doing now, which is a thrill for me, I've decided to learn to play the guitar. I'm taking classical guitar lessons, and it is an amazing trip. It's so beautiful, and it's something that I have to learn to read music, to transfer that information, those dots on the page, to where I put my fingers. It's a wonderful experience, and I just feel so, and that is a brain exercise too. So I just thought to mention
Great.
that. It's something
Great.
anybody could do.
Thank you. I think also what Adrian points out is the importance of our conducting research that is not deficit-based, but also asset-based, that continues to look at the resiliency that does exist and that is mindful of the way we do in the real world live our lives, all of us. None of us is perfect. We've all of us dealt with many, many issues. I know over the years, I've tried to become increasingly mindful of the degree to which I am my mind, my body, and my spirit. And I thank my Aboriginal colleagues for also helping to remind me that there's a fourth element involved, and that's the environment. So I'm thankful to them. I think that in summarizing what I'm hearing today from our panelists is, first of all, the importance of interventions, which can make a huge difference in our health. There are things we can't change. Our genetic, our family history, our genetic background, and many of the social determinants of health, which may make dealing with these modifiable behaviors extremely challenging. But I would certainly encourage our researchers to do more investigation of comparative interventions which compare medical versus non-medical in a way that would give us good information and reliable information that would enable us to make decisions whereby we might choose to use a statin in a certain circumstance, or we might decide that exercise could be sufficient. But I think we would all appreciate having better information in order to make those kinds of health-seeking decisions. And I think we've also heard in a number of cases about the importance of early intervention and prevention in terms of dealing with problems that may get worse as we are, many of us, aging with HIV, and the importance of early and holistic intervention. Thank you all very much, and I'm going to pass it over to our conference chairs.